The content of this podcast is for informational and entertainment purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your healthcare provider with any questions you may have regarding your mental or physical health. The views expressed are those of the host and guests and do not replace personalized care from a licensed professional.
Welcome to Mindful Moments with Pedro Morante, a space where a nurse practitioner and educator shares real talk on mental wellness, mindfulness, and navigating life in and out of healthcare. Let's take a moment to breathe, reflect, and grow together.
Welcome back to the podcast, Mindful Moments with Pedro Morante, where we explore the heart of nursing, the power of evidence, and the leadership it takes to create real equity in healthcare. Today's conversation is about more than the titles, publications, or professional milestones. It's about calling. It's about the moments that quietly and sometimes painfully shape who we become as nurses, educators, and leaders. Our special guest today sits at a powerful intersection. She works at a clinical practice, education, research, and also advocacy. As a psychiatric mental health nurse, an educator, and an editor-in-chief, they've spent their career asking not just what does the evidence say, but what does it serve and who is it still being left out. In this episode, we'll go back to the beginning. Before the leadership roles she had, she explored what first drove her to nursing, and we'll talk about the moment she realized education could be a tool for equity, and how working alongside underserved and underrepresented communities reshaped the way she led today. We'll also dig into the hard truths, the barriers that still keep marginalized voices out of the nursing profession, and also the risk of allowing psychiatric research to live only in journals instead of at the bedside, and why evidence-based practice is not optional but very essential in mental health care. For anyone who has ever felt intimidated by publishing, discouraged by rejection, or unsure whether your voice belongs in this research and scholarship, this conversation is for you. We'll pull back to the curtain of peer review, talk honestly about why manuscript struggles, and explore how growth often hides inside rejection. Finally, we'll reflect on a mindful leadership, what it looks like in day-to-day, how institutions and journals can do better at lifting underrepresented voices, and what it truly means to lead with intention, equity, and evidence. So whether you're a student, clinician, educator, researcher, or leader, settle in. This conversation is for you, about purpose, responsibility, the power of nursing voices when they are heard. Let's begin with our very special guest, Dr. Michelle Hampton. Woohoo!
Hi, thanks for having me.
Thank you, Dr. Michelle Hampton. Finally, this coming to fruition, and thank you so much for your time. And with your busy schedule, thank you for squeezing me in.
Same to you.
So for today's episode, we will talk about your titles and leadership roles and what originally called you to nursing. So everybody in that are following with this podcast and listeners are able to know you well.
Thanks for asking. So I think I have kind of a unique journey into nursing. I know when I first started in teaching, I would always start by asking my students what their motivation was for getting into nursing. And they were such inspirational stories, like maybe a family history of nurses, or, they had a catastrophic injury and they really valued the time that they spent with their nurses. But for me, it was kind of more of a practical entry into nursing. And my calling came much later, maybe even like 5 years after I had my nursing degree. I went through a second degree program. And then about 5 years after I got my license in 1994, I started working in an assertive community treatment program. And in that program, we case managed the 100 highest psych service users in the county, the ones who had costed the county the most money. And I found that working with people over longer periods of time, seeing them make small but still meaningful changes and progress in their conditions was where I really found the most meaning and was really feeling like I found my purpose, like this was the place that I belonged. And so these were people with severe mental illness. I really, to this day, I think that's one of my favorite clinical experiences that I had.
I'm glad that you shared that to our audience and we get to know you, Dr. Michelle. I know you're very active in LinkedIn and other social media platforms. And that early call often holds so much truth about you. And as you reflect on that moment, how do you see that original motivation is still showing up in your work today, even after credentials and responsibilities have grown?
Well, I feel like I'm really privileged to be in the role of editor of the Journal of the American Psychiatric Nurses Association because I have the ability to look at the research literature that's coming in, and the decisions that I make are really shaping what the practitioners see in our society journal, and the things that I have the opportunity to emphasize, things that might be priority issues or even things that aren't getting a lot of attention. I can try and work with authors to get those things in and get them published. And so I love that I have the ability to bring together both my deep commitment to people with severe mental illness, as well as my love for writing and publication. And, I was kind of an English class nerd back in high school and everything. So I love that I get to integrate that with my nursing career.
I'm so impressed and also able to resonate with your passion with mental health. And that's so very important right now, right? In your journey, what was the specific moment when you realized education could be a tool for equity?
So this came pretty early in my career in academia. I started in teaching at the university level in about 2005, and every faculty member who had was responsible for undergraduate teaching also had a small load of students who were they were advising. And it was towards the end of the semester, and I had a student of color who was failing. And, there are very dire consequences, as you know, for students failing a course once they're in the nursing program. And so I was ready to dive in and talk to her about study skills. And I thought I'd be able to help with problem solving, but it was so late in the semester. And then as I talked to her, I learned this student is incredibly bright. She just hasn't had time to study as much as the others because she's working full time. She's paying her own rent. She's got bills. She's got a car note to pay. And I was just flabbergasted. I guess this was the first time that I kind of realized my own privilege, because even though I went to this master's entry program and I was living with my mom between the ages of 24 and 26 while I was in this program. And she took care of me. She fed me, she paid for my car and everything, which was really what made the difference in me being able to access nursing education. And when I saw that the student was completely independent at a younger age than even I was when she went nursing school, that's when I realized how big a difference all of these little things that go into supporting a student can make the difference in their success or their failure. And you can try to jump in with a fix like study skills, but if that's not the issue, then it's not going to help that student. So that was a light bulb moment for me.
That's a very eye opener story, and that realization can also be transformative for us as clinicians and also educators.
Mhm.
How did it change the way you approach teaching, mentoring, or even on your own scholarship moving forward with that experience?
I think that experience taught me to try to go into these situations without preconceived notions. I try to go in asking questions before I've developed a whole plan of how to help this student. Like I said, I was thinking of how to help her with her study skills and sitting down with her and going over questions and things like that. And I had gone, you know, 10 steps down the road, and it wasn't anything that was going to help her at all. And unfortunately, I wasn't able to help this student, but I do, when I'm teaching courses, always make it a point to make sure students know that I'm available for questions, information, making myself look more accessible to them and more warm and fuzzy, just so they won't hesitate to reach out. I feel like that's really important. And I am more on top of getting grades out to students earlier and substantive feedback so that if there is something that's going on, I can identify what it is, provide support, and they still have time to kind of come back from it if they didn't do so well on an early assignment or an exam, and making sure that you have enough assessments for students to rebound who might need to figure out, how things are working in this class to be successful. And that's totally normal part of the learning process that I think sometimes we don't value enough in education. We shouldn't expect students to come in knowing everything. They should learn while they're in our classes.
And that's an important piece of being an educator, is to be always having a great communication or a therapeutic alliance with the students.
Mhm.
Because sometimes students could have like a wall, right? Like they feel like they cannot approach their teachers or their professors for certain issues or concerns, like they're shy about their personal concerns or issues in the classes.
Yeah, and I think that's something we especially see with students from underserved and underrepresented communities. They often don't know that it's even an expectation that students go and talk to faculty. I know I had that feeling probably through my entire college career, even up through and including my master's program. It wasn't until my PhD program that I really developed a strong relationship with an academic mentor and gained the benefit of that partnership. And now that I'm in education, I see students are reaching out all the time and have no hesitation in asking questions and kind of even demanding, like, I need to know this. I want an A in this class. And I don't know that the rest of us are socialized in that way, in expecting that from our educators.
I agree with you, and there's like a common trend right now that it's changing from our traditional standpoint to newer batch of learners.
Mhm.
Now, how has working with underserved and underrepresented communities shaped how you led today?
I think what it's taught me, and it's been a process of development over my entire career, but I feel like things really took a turn during the pandemic. And, that's when we started having more conversations about how are we serving our underrepresented or our minoritized populations. And if I were to kind of sum it up in just one thing, I would say it's really important to be in the room where decisions are being made, whenever you can, and just being there. Even if every time an issue comes up, it doesn't necessarily go the way that you think it should or that you hoped it would, being there consistently does in fact make a difference. So I've been on hiring panels, rank and promotion committees, admission committees, and I do feel like I've been able to have an impact in a lot of ways. And even though it can be really a lonely experience, an uncomfortable experience when you're the only person in the room, I just feel like it it means so much to be there. I don't want to take that for granted. And so as long as I'm able, I'm going to try to get myself in those rooms. I'm going to try to advocate where I can, because I have seen it make a difference. And that's where you have to be patient, look at it as a marathon rather than a sprint. And then you can wait and see when those changes can take effect.
Those are strong points, and it sounds like those experiences didn't just inform your leadership, they actually reshape it. Now, what lessons from those communities do you feel are still missing in traditional leadership spaces?
I think anytime you have a very narrow group of opinions or a certain group of people, their mindset is always going to be from their own frame of reference. I was chatting with somebody yesterday about privilege, and I often liken it to like when I was a runner. I would sometimes, after I graduated and I was no longer running, sometimes I would run into somebody who I had raced before, and they might come up and, be excited to say hello because we hadn't seen each other in so long. Often I wouldn't necessarily remember who they were because those might have been the people that were coming in behind me, but I could remember the names, the color of the uniform that the people wore that were in front of me. And so you're very keenly focused on the things maybe that you don't have versus all the things that you do. And so I feel like if you don't have a diverse group represented where you're making decisions about things in academic settings, in clinical and healthcare settings, business environments, then there's no way you can really expect that other people's needs and desires will be represented.
Thank you for emphasizing that. Now, for those issues and concerns that we have, what barriers do people from marginalized communities still face when trying to enter the nursing profession?
I thought a lot about this one, and what it brought to mind was when after my daughter went to college, I did some volunteer work for the Salvation Army, one of the sites in Oakland where I live, and I met a young mother. She was living in the transitional homeless shelter. She couldn't have been more than 20 years old, and she had this infant and no support, no family. She told me that she had wanted to be a nurse at one point, and I can feel sad now just thinking about it because even at 20 years old, she seemed to be resigned to that it would never happen for her. And so I was still feeling very optimistic, and I thought I could help her figure out how to do it. But knowing that she didn't have a place to live, she didn't have a job to pay tuition, she didn't have childcare, which would have added to her expenses. I thought, even if we brought the hope or the original goal down to something a little more manageable, like a 5 or 6 week CNA program, even that seemed impossible when seeing that the cost associated with it was $1,500 and, still all the living expenses and the childcare. I just felt really stumped at the time and disappointed that I couldn't come up with anything that I thought would be meaningful. And, fortunately, I had the opportunity later, maybe several months or a year later, to continue working with Salvation Army. And we were able to work with their vocational center, and they have now added a CNA program and scholarship for people in the community, even not just the people that are in the homeless shelter, but they might have low income, they're in the community. And so since then, more than 150 CNAs have been trained, and many of them have gone on to study to become LVNs or RNs. So even though I wasn't able to help this particular prospective nurse, I always hope that when I go to their graduations, maybe she'll pop up one day and I'll see her, and maybe she could get on the road to doing that as well. But she was the inspiration for that program. It just, it's those kinds of barriers that I think are most impactful. Nursing education is very much set up for kind of the rich to get richer. You know, if you have a solid educational foundation, you've got financial resources, you've got adults and peers around you with knowledge and experience with higher ed, you're bound to succeed with that kind of background. But if you don't have those things, if you are in living and supporting yourself independently, it makes it a lot more difficult to get into nursing. Not to mention, so many of students from minoritized or marginalized groups are working and supporting themselves, and nursing education is not at all set up for working adults.
Thank you. And when we name these barriers out loud, they can feel sometimes uncomfortable, but often necessary. Now, which of these barriers do you think we underestimate most as a profession?
I think the biggest barrier, and it's something that I'm hearing a lot more from faculty at different universities, is that almost all students are working and working a lot. Many of them have full-time jobs, multiple jobs, and we talk about their performance quite often, but not necessarily thinking of the role of all of those hours spent working, trying to support themselves, trying to pay their tuition. And I think we're kind of missing the issue, because it's, again, not about their study skills. It's about how much time they're spending just trying to survive from day to day. And they're very committed to becoming nurses, but it's hard work and it takes a lot of financial resources. So how do we ensure that students have the bandwidth and the time to study, and they're still able to live, you know, they're not living in their cars or something like that?
I agree with you, and there's so much things that we can look at because being a full-time student and they're also working full-time, it puts a lot of time constraints on their studying. Sometimes there could be challenges in terms of them absorbing the material and also showing up 100% in clinicals, right? That's
For
very
sure.
important that we also work with them and identify those barriers and help them and mentor them and make them realize that over time these sacrifices will be fruitful because all of them wanted to become a nurse. At the end of the day, they all want to have financial stability at the same time, loves helping people out.
Mm-hmm.
Now, this is my favorite question. When you think about mindful leadership, what does that look like in your day-to-day work?
So I am kind of a late adopter to the mindfulness movement. So, but I have so appreciated it in my life, and I really appreciate you asking this question. I think we're leaders in so many ways, both formal and informal. You know, we're leaders when we're in our classrooms with our students, our professional organizations. We're leaders with our patients. We have committee work. So there's so many ways that we can be leaders, even if we don't have a particular title. But I think what I have worked to evolve in my leadership approach is to work most on my presence. I have a tendency to be a problem solver. So, you know, you say one thing to me, I'm already strategizing, you know, multiple steps down the road, similar to the story I told you earlier. And so my goal is to be just present with the people who work with me, that I feel my biggest the biggest need that they have from me is to listen and support them. And often, those times when you've had somebody who really listened to you, just through the process of speaking, you kind of figure things out on your own. You just needed somebody to listen to you. And I think that happens a lot with others when that's our approach to leadership. And I know that in any sort of setting, especially in healthcare, especially in academia, when we're so stretched and our resources are limited, it's never going to be a perfect situation. But I always want people to know that I'm being honest with them, that I'm accessible to them when they need me. And I think when you go into situations and you approach your relationships with others in that way, even when the work is hard, I think that helps to build the type of environment that I know I enjoy being in most. And I hope that I help to create a positive and supportive environment wherever I am.
That's very important. And mindfulness can often sound abstract for some. Can you share a moment when practicing mindful leadership changed the outcome of a difficult decision or conversation?
I'll say it probably was when I worked for an organization, and there's those times where you have somebody that you work with and there's a real synergy and they're so enjoyable to work with. You rely on them for so many things. But this role had become burdensome for this person. And so in taking the time to listen to them, rather than, of course, my initial thinking is what it's going to mean for me if they're leaving this role and the kind of chaos that can ensue when you have to fill a really vital position. But when I just stopped to listen, I could hear the toll that it was taking on this person. And I didn't want to contribute to any sort of distress that they had in making that decision, which I know was incredibly hard for them. And so rather than trying to talk them out of it, I also didn't try to push them into it any quicker, but I wanted to let them know that I hear what you've been experiencing. That's so difficult. I'm here to support whatever decision you make, and that's best for you and your family. And so the person ended up leaving the position, and things always work out, even when it's not how you wanted it to be, or maybe the timing wasn't great. But there's always a way to work through any situation, and that was the best decision for that person.
That's very transformative. Now, we talk about evidence based practice all the time. Why is it especially critical in psychiatric mental health nursing?
I think it's especially critical in psych mental health because even patients who we wouldn't otherwise consider as marginalized, if we're thinking about their race or their socioeconomic status, just the label of having a psychiatric disorder alone, that places them in a marginalized group. And similar to other marginalized groups, they experience health inequities, shorter lifespans, poorer quality of life, and one of the best ways to kind of counteract those things that we do based on bias or assumptions is to go back to our best evidence, to our research based interventions. And that's the way that we can have a better chance of improving their care and their outcomes.
Okay, that's very important. And we know that psychiatric care sits at the intersection of science, stigma, and even lived experience. What happens to patients when evidence isn't applied or when it doesn't reflect who they are?
This is something I teach research, so I talk pretty much every year about we have this lag time between research findings and when it makes it to the clinic or the bedside being estimated at about 10 to 15 years. And I've been working with D&P students for about the last 14 years. And, that's being seen as one of the sweet spots for getting evidence into practice. So that's what I find most exciting about working with DNP students, is to shorten that time frame. But there, for example, I just recently accepted a paper for the journal that had to do with first episode psychosis treatment. And when I first started in mental health care, when I was coming out of school, it seemed to be the belief that there's really no way of knowing or having an impact on the trajectory or severity of schizophrenia. There were just some people who did really poorly and were in and out of the hospital all the time. And there were some who could take a small dose of their antipsychotic and they'd be fine and they could have a job and a meaningful life. So when we started learning about the duration of untreated psychosis and there being improved ways of identifying people who could be developing schizophrenia, I think that kind of revolutionized care in terms of schizophrenia treatment. But who has access to that? Is it an insurance issue? Is it an issue of location where they can find settings where they can get this care? Or is it just, do people even know about it? So if people aren't reading the literature and knowing that that treatment even exists, even if somebody has the resources, they might not be able to access what can be life-changing for people. It can change the whole trajectory of their illness. It can lead to them having a life where they're functioning in a way that no one would even know that they have schizophrenia. So I would say that's one of the biggest challenges with doing work that is meaningful, which is great. And sometimes we have research and studies that are going on that are applied locally. But when you can share it in a journal and when you're going around to conferences and presenting, you can reach so many more people. And in doing that, so many more patients. So I love to help people to get their research and their study findings into print.
And we reach more people, and research dissemination and publication are really important role as a clinician, as a nurse, and healthcare workers, because we are able to spread the information to the public.
Mm-hmm.
What's at risk in psychiatric nursing when research stays trapped in journals instead of reaching patients?
Like if you're doing work and you present it at a conference, you've often got 15 or 20 minutes to present it, and people might hear about it and they might be able to go back and apply some semblance of it. But when you put it into print, you can detail more of your methodology. You can provide your contact information so people can reach out. They can get more information about what you did, things to look out for. So I always advocate, even though I love a good conference, I always feel so inspired after going to those. But when it comes to information that I'm going to use, I often find myself going to research literature, to journals, to articles, because that has the most information, and it's easier to access, I find, than, you can go to a website and try and dig up an old recording or maybe someone's slides, but the meat of a study, you're always going to find the most of it in a research article.
Thank you for stating that. And that gap between research and practice can feel invisible.
Mm-hmm.
Can you share a specific example of how making evidence accessible could change care in real time?
I like the examples of like a hospital setting. I was working at Stanford for a couple of years, and they had a research department and a quality improvement department. I just thought it was so exciting that they had these so many structures in place for not only the consideration of evidence, but its application. And so I thought they had a great model of how they were doing that there. So for the research side, that might be exploring a question that hadn't been explored before and learning how to do something in a certain way. But then on the quality improvement side, they can figure out what are the steps that need to be put in place to get this into a particular unit. And if it works well in that unit, then let's expand it to additional units or across this whole platform. So when you have that kind of support for scholarship in that way, and that comes from the leadership, you are able to see those changes getting put in place in clinical application. So I just thought that was a really exciting place to be while I was there.
Nice, and those are great experience that you had. And this next question focus on more about fear and rejection. Many nurses feel intimidated by publishing. From your perspective as editor-in-chief, what do you wish more clinicians understood about peer review?
Okay. What I try to convey to people about peer review is a lot of times people will see it as a burden, but I've found that it's one of the absolute best ways to learn about what's needed for a manuscript to be published. And you can look at it as a completely self-serving learning process for yourself. You're still doing a service for the journal, for your professional community, but it's really serving you as well. So even though I've been doing this for more than 30 years, just the volume of papers that I'm reading now as editor, I continue to learn every day. And it was between submitting my own papers for peer review and being a peer reviewer, because when you get those reviews back, say you peer reviewed for a journal, you will, when the editor makes a decision, they will send out the decision to the author, and the peer reviewers are CC'd in an anonymous way. You won't know who the email went out to, but you can see all of your own feedback to the author and any other reviewer, and that might be one or two additional reviewers, and all the details of what they had to say and the feedback they gave to the author. And if you take the time to look at that, in addition to doing a really thorough review yourself, every time you read a new paper, you're going to take away something meaningful about research methods, about interpretation of results. These are going to be papers in your area of interest. So you're learning about new studies that have been conducted in your area of interest, growing your expertise in that area. So it's always a win-win from my perspective. You know, of course, people don't have a lot of time to dedicate to it. So I'm always so grateful when they take it on. But if you feel like you would really like to build your skills as a writer and as a reviewer, when those email invitations come, I would strongly encourage you to accept the invitation and, you know, set that time aside on a Saturday morning and read that paper and start the learning.
That's great, and basically needed to hear by a lot of nurses out there that wanted to start publishing their work. And what are the most common reasons manuscripts struggle, and how can authors grow from that instead of getting discouraged?
So I have quite a few things that I can share on that. And so one thing that I do when articles come in is, you know, even if it doesn't necessarily meet the criteria of what I would send out for peer review, I do try to give them some specific feedback about why that happened. So some of the things that are most common are just a really basic one. Does the topic of study fit with the aims and scope of the journal? So before you pick the journal that you want to send it to, Google search the aims and scope for that journal and see if it's a match. You also want to look and see if it is the type of journal that publishes papers that are similar to what you did. So, a lot of my studies have been small samples. I've had some qualitative, some quantitative, but not very big. So it wouldn't make sense for me to submit to an epidemiology journal when they're publishing studies with thousands of patients or participants. My paper just isn't a good fit. It might have been a good study, but if it doesn't fit that very basic criterion, you'll likely get an early rejection. Another thing that comes up is plagiarism. So all of us have plagiarism detection software in there. And I think a lot of times it can be inadvertent if you're thinking about, when do you take notes from a paper that you're reading and then put it into your paper. You can often lose track of when you did your paraphrasing or if you did your paraphrasing. So I know that it does happen, but you do have to check those things. And sometimes there can be, I've seen full paragraphs that were lifted from another paper. And so you just want to be very cautious about those things and be systematic about keeping track of when you're taking information from a paper and when you're going to paraphrase it when you're putting it in your paper.
For those advice, and those are great points that we want to make sure to take note of. And we needed that growth often comes from discomfort. What advice would you give to a nurse who's questioning whether their work or their voice is good enough?
I am a strong believer in everybody having something meaningful that they can contribute. It's just figuring out how to put it into words that are clear and in a structure. If you're talking about publishing, in a structure that is consistent with a manuscript that's going to be published. So I think all of those things can be learned. I don't think writers are born. I think they just work at it and they listen to feedback, because every time you start a new paper, no matter how experienced you are, someone's going to have lots and lots of feedback to give you. And you often feel like it's painful to take that in. I still feel it often just because I'm ready to be done with the paper and move on to something else. But I've always genuinely felt that after I've taken that feedback and incorporated it into my paper, it's made it so much better. And so I look at feedback as a gift. And if we look at it that way, and sometimes you just need a little break between when you've gotten the feedback and when you act on it. And then you can, you often feel a little better about it after that.
Yes, and consistency is the key, and constructive feedback are really important for quality improvement.
Mm-hmm.
Now, whose voices are still missing in nursing and psychiatric research, and why does that matter?
I think there's always a need for more patient voices in care settings and research. I think psychiatric mental health care particularly has been historically very paternalistic. And so often providers and caregivers are making decisions for patients possibly without their input at all. So I think that's always something we can work harder to do, is to bring them into discussions, engaging them in their own care to whatever degree someone might be able to do. And I think, like anything, when you engage people in that, they're more likely to participate and to maybe stick with the program if they were part of making the decision about it.
And also, we need to partner with institutions, journals, and mentors to be more intentional and about lifting underrepresented voices. Now, intentionality requires action. What is one concrete shift you believe that they could do to make the biggest difference right now?
To be more intentional about lifting underrepresented voices. So That made me think of a TED Talk by Dr. David Williams. I would often assign that to my students to watch. It's called How Racism Makes Us Sick. And one of the things that he talked about, he called the secret sauce that has the potential to erase racial differences in income, education, and employment. And we could presume healthcare also. So, what he said was the issue of racial segregation is what we could focus on. So, with that in mind, I would say that the most impactful thing for us to do would be to be sure that underrepresented voices are present in every room where decisions are made, when we're able to bring those people in. And so the question would be, who's taking the initiative to first ask the question, do we have the people represented in this room that we need to hear from? Second, if you don't, take action to invite those persons into the room. And then third, to ensure that when they're there, that they're actually heard and are a meaningful part of the process.
Thank you for that. And we need to make sure that we also emphasize on our partnership with them. And one way of get involved is to be a member of different local organizations too, nursing organizations. Now, if you could leave our listeners with one mindful reflection about evidence, equity, and leadership, what would it be?
I would say, I actually just wrote about this in my last editorial. So I think leadership has such an important role to play in any sort of, you know, vision or mission that we have, and making sure that it gets carried out. So no matter how well designed or innovative an organizational change initiative might be, its success or failure rides entirely on the active presence and engagement of leadership in its implementation. Merely allowing it to take place isn't enough to see the buy-in that we need. I think people very much look to the leaders to see, are they being involved in this? Should I invest my time in this if they don't support it? And so being present and showing active support is so important when we're trying to advance a mission that we truly believe in.
Let's talk about rapid fire reflections. What lesson rejection taught you about leadership or growth?
There was one time that I got a paper rejected from 3 different journals, and it was that third time that a reviewer gave me some really meaningful feedback about how to frame and contextualize my findings. And once I did that, it was published in the next journal. So in the end, it was worth the pain. I always value the feedback that I'm given. So there's always something to be learned in a rejection.
And that lesson feels universal. Is there one message you want every nurse or educator to remember about their voice and their work?
I think we each care so deeply about our work and have something to share that means a lot to us. Like I said, great writers aren't born. They develop over time with lots and lots of practice. So like the saying of a journey of 1,000 miles beginning with one step, the steps that we take for pre-writing and writing, those can all be broken down into very structured steps. And once you learn an approach that works best for you, you can reproduce that over and over and become a more productive writer. And you don't even necessarily have to ever feel like you're a great writer. I don't know that everybody gets to a point where they feel that way, but you can be clear and you can share information that will be beneficial to other providers, to patients, and that's the goal for me.
Thank you, Dr. Michelle. You're so inspirational. For those who are listening into this podcast and following this, I always ask my guests, how do you take care of your mental health?
For me, oh gosh, I have gotten so much better with this in my older years. So often when I would wait until I got to the point of feeling completely overwhelmed, then I would shut down and do nothing for like 2 or 3 days. So now I have a much better self-care practice to prevent getting to that point. So I get up in the morning. I am very mindful with my enjoying my cup of coffee, smelling it, making sure that I'm not really turning on the TV while I'm drinking my coffee, just relaxing, having a slow build up into my day. I was a runner when I was younger and got away from working out. Now I've got um, my workouts back in my day-to-day program, and that makes a big difference for so many things, not only just endorphins, but you sleep better and things like that. And I cook more than I used to, especially when my daughter was younger. You'd think you'd cook more when you had younger kids, but it was hard. We were really busy, so I bought a lot of takeout. So now I'm back to cooking more. So just those very little things, your nutrition, your hydration, your rest, and just taking moments in the day, just do nothing and be mindful.
Thank you, Dr. Michelle. Oh my God, we went over an hour. Thank you so much for your time today. You are inspirational. Now, where can people follow you and message you via Facebook, Instagram, or LinkedIn? Where can they follow you if they want to connect with you and publish their work?
LinkedIn is the best way to engage with me. That's probably where I spend the most time of all the social media that I'm on. But I also have an account on X and Blue Sky Social. I am very reachable through LinkedIn, and if anyone is interested in publishing for the Journal of the American Psychiatric Nurses Association specifically, they can reach out to me and schedule time in my office hours, or send me a message on LinkedIn, and I'm happy to respond there.
There you go again, Dr. Michelle Hampton, one of the most powerful voice that we have for our nursing community. Thank you so much, Doc, and hopefully we get to do this in person or more collaboration, more topics that we can talk about.
That would be great. Thank you so much for having me. I had a good time.
Thanks for listening to Mindful Moments with Pedro Morante. Be sure to follow the podcast so you'll never miss an episode. If you find value in our time together, leave a quick review. It helps more people discover the space we're creating. For updates and more reflections, follow us on social media. Until next time, take care.